and pathogenesis, Sydenham versus PANDAS, and comorbid diagnosis, and investigations, management, and summary. Coming on to the first topic, PANDAS versus the PANS. PANS stand for Pediatric Acute Onset Neuropsychiatric Syndrome, and PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders. Basically, the difference between the PANS and the PANDAS is if we add streptococcal infection to the PANS, then it equates to the PANDAS. The only difference is this: PANDAS includes for the streptococcal infection. Nothing much difference other than it. Coming on to the introduction, the term pediatric autoimmune neuropsychiatric disorder associated with streptococcus infections was coined by Swedo et al. Group A beta hemolytic streptococcus pyogenes infection can lead to subset of childhood onset OCD and tic disorders. Like adult OCD, PANDAS is associated with basal ganglia dysfunction. A probable link between the group A beta hemolytic streptococcus infection and characteristic symptoms of OCD has been postulated by observations of patients with rheumatic fever who also had Sydenham's chorea. This is only one subset of OCD sufferers. Additionally, group A beta hemolytic streptococcus has been linked to children's development of autism and Tourette syndrome. Despite growing a support for an association between the GABHS and the OCD, the causal relationship between the GABHS infection and OCD, its pathophysiology and its possible clinical implication remain highly controversial. Coming on to the historical perspective, in 1994, Suzanne Swedo reported the case of a 9-year-old girl with rheumatic chorea and OCD whose neuropsychiatric symptoms responded to plasma exchange. The neuropsychiatric characteristics of rheumatic fever and studies on Sydenham's chorea patients showed symptoms of obsessive-compulsive disorder that were up to 70% of the time identical to those of the typical OCD. In 1995, Allen and colleagues reported on 4 patients whose group A beta hemolytic streptococcal infection concluded 2 cases or viral infection included 2 cases called OCD or Tourette syndrome to appear or deteriorate. This patient responded to treatment with plasmapheresis, intravenous immunoglobulin, or immunosuppressive dosages of prednisolone. To summarize, these Allen and et al. Coined the term PITANDS, PITANDS, which stands for Pediatric Infection Triggered Autoimmune Neuropsychiatric Disorders. Later on, in a follow-up study published in 1998, Swedo et al. Revised and expanded the PITANDS diagnostic criteria, eliminated any reference to viral or other bacterial illnesses, and proposed the possibility of PANDAS. Coming on to the diagnostic criteria for PANDAS, the presence of OCD or a tic disorder or both is the first criteria. Second criteria consists of pediatric onset, and the third criteria includes episodic course of symptom, severity with abrupt onset, or dramatic symptoms of exhibitions. A temporal association with GBHS infection is the fourth criteria. Fifth criteria includes of association with neurological abnormalities during symptom exacerbation, which majorly includes coriform movements. The controversies regarding the diagnosis: a childhood onset of symptoms, which is the second criteria, may lack the specificity needed to distinguish PANDAS from the Tourette syndrome, because in up to 75% of Tourette disorder cases, the manifestation begin during the prepubertal period, which is different in the PANDAS, right? Most children enrolled in the PANDAS study manifested several neuropsychiatric comorbidities, especially attention deficit hyperactivity disorder, anorexia nervosa, or separation anxiety disorder, etc. In the fourth criteria, neurologic abnormalities consist of coriform movements. Coriform movements are basically included in Sydenham chorea, which are dancing movements present, like these are involuntary, uh, hence becoming a specific criterion. But coriform movements are still a major part of Sydenham chorea, so we can't differentiate between the PANDAS and the Sydenham chorea. So it is also controversial. A temporal association between the GABHS, whose incidence in school-age children is high, but it is not specific, as streptococcus are not the only infectious agents implicated in Tourette syndrome. Other pathogens like include Borrelia burgdorferi and Mycoplasma pneumoniae. Coming on to the pathogens of panda, I will further evaluate. I will go into the deeper side in this pathogenesis. Uh, I will begin with this group A beta hemolytic streptococcus infection. Like these release um, majorly कहते हैं antiviral, not antiviral, basically release the M-like proteins as streptolysin O and S. And M-like proteins, these are two types basically released by them. First, they mimic the cardiac proteins, and secondly, M-like proteins like M6 and M19 are common with the brain peptide epitopes, which mimic the brain epitopes. When the group A beta hemolytic streptococcus infection occurs, these can lead to rheumatic fever. We all know about it, which usually involves the heart, joints, skin, and brain. When it includes the brain, this leads to neurological manifestation, which I earlier told coriform movements. The neurological part is usually associated with Sydenham's chorea. Further, Sydenham's chorea is further leads to antineuronal antibodies and anti-basal ganglia antibodies. Autoantibodies, which are IgM autoantibodies. The type of infection caused by them are type 2 hypersensitivity reaction, which we call the molecular mimicry, and leads to cross reactivity. Leading to the cross reactivity, usually these antibodies do not cross the blood brain barrier until or unless there is there is a space which is present in lamina terminalis. In lamina terminalis, there is a loophole through which they can enter the blood brain barrier and attack on the basal ganglia part of the brain. Other than that, if there is inflammation in the body throughout, it can lead to the breakage of the bond between the blood brain barrier. If there is the breakage in the body in the blood brain barrier, this can lead to again then can lead to antineuronal antibodies and anti-basal ganglia antibodies can reach to the basal ganglia, and this can lead to the infection, and then leading to the Sydenham's chorea and the PANDAS infection. Coming on to the Sydenham chorea versus the PANDAS, there is a differences. Like in difference, first difference is between the age. Like age differs between 5 to 15 years and 6 to 9 years, and male to female ratio is also different. Like 1:1 is in the Sydenham's chorea and 2.6:1 is in the PANDAS. PANDAS usually has a relapsing remitting course, but Sydenham's chorea remains for 1 to 6 months. The time lag between the inciting infection is longer in the Sydenham's chorea, but shorter in the PANDAS. Uh, Association with the carditis, arthritis, and presence of chorea are usually common in the Sydenham's chorea, but rare in the PANDAS. Presence of tics and the presence of OCD are characteristic in the PANDAS. Antineuronal antibodies and anti-basal ganglia body antibodies are common, but the difference in the last, like M6, like protein that I had told, are present in the Sydenham's chorea, and M12 is more common in the pandas. So this is where the differences come between the Sydenham's chorea and the pandas. Other symptoms of pandas include symptoms of ADHD, which is attention deficit hyperactivity disorder, separation anxiety, mood changes such as the irritability, sadness, or emotional lability, trouble sleeping, nighttime bedwetting, daytime frequent urination, or both, changes in the motor skills such as changes in handwriting and joint pains. So coming on to the episodic course of symptoms, the degree of OCD and tics in children with pandas appear to fluctuate dramatically. Usually, in the normal tics or disorders that are essentially constant or almost constant do not indicate an episodic course. On the other hand, symptoms in the children with pandas, uh, these increase over the time, and then suddenly normally they get better slowly. Child diagnosed with pandas experience an abrupt worsening of symptoms if they reoccur with the strep throat. The increased severity of the symptoms often lasts for a few weeks, but it can sometimes last for several months or longer. Coming to the OCD symptoms present in the PANDAS children and their relation with the primary OCD and primary tic disorder. Majorly, obsession consists of contamination, uh, which is a part, and then in the compulsion part, washing, checking, cleaning, and spitting are the majorly uh, seen in these. In comorbidities, ADHD is the prominent, and then oppositional defined disorder is also very common. And least is the psychosis and somatization disorder, which can be seen in these pandas. Coming on to the investigation, if they come in our OPD or they get admitted, we can go with the basic blood work. We can go with all of the IG antibodies, and then basically with the CBC and antineuronal antibodies we can go. And ferritin and B12 vitamin D deficiency are basically done in investigations done with them. Coming on to the viral and bacterial testing, strep throat culture obviously should be done in the 48-hour period, where as it has an abrupt course. So, and enterostreptolysin, as this is O, which is released by the group A beta hemolytic streptococcus, and anti-DNase B antibodies and streptozymes can be checked. Coming on to the neuroimaging in the pandas, it was very difficult to find them, and these are very varied over the time. Like guide in et al. In the 2000s of in the MRI early stages of the panda found out that there is a larger chordate putamen globus pallidus volume in the pandas versus the control. But Kumar in et al. In 2015 in the mixed stages in the on the PET scan found out that activated microglia in bilateral chordate and the bilateral lentiform in pandas versus controls, and bilateral chordate only in the torrid versus the controls. Carbera et al. In 2019, again on the MRI in the mixed stages of panda, found out that greater gray matter volume and reduced white matter volume in the basal ganglia. Zheng et al. In the 2020 in the MRI mixed stages of the panda, found out that there is increased diffusivity throughout the brain, most prominently in the thalamus, basal ganglia, and amygdala. So results have been varied over the time, and there is no as such proper result we have found out. In the management part of the group A, in the group A beta hemolytic infection and the pandas, firstly, if there is an infection, we find out over after the investigations. We will start with the therapy for the group A beta hemolytic streptococcal infection, and then we will come for the neuropsychiatric symptoms. First, we will start for the GABHS infection. We will start with the beta lactams, which are the most effective antibiotics for the group A streptococcal infections. These include penicillin, amoxicillin, and cephalosporins. The response to the antibiotics may happen quickly. In some cases, putting OCD, anxiety, and other comorbid symptoms of PANS and PANDAS into full or partial remission within 24 to 48 hours. However, the typical response happens after a week or two of therapy. Coming on to the therapy for neuropsychiatric symptoms, these usually begin with the standard pharmacological and behavioral therapies. For OCD symptoms, we in the pharmacological part, we start with the SSRIs as the first line management. Non-pharmacological part, we can start with the ERP, which is exposure and response prevention therapy, is considered first line non-pharmacological treatment. For tic disorder, tic and Tourette syndrome, we can start with alpha-adrenergic agonist, which is clonidine and guanfacine, and atypical neuroleptic agents like risperidone, and typical neuroleptic agents like haloperidol or pimozan. Coming on to the immune modulating therapy, these are usually done within the inpatient setting only. Note with the OPDs, we can come with the IVIG replacement therapy, which involves the use of immunoglobulin solution to treat the immune deficiencies, encephalitis, and other medical conditions. A consortium of physicians and researchers endorse using IVIG treatment in treating the pandas. There's still of a lot of research that researchers don't fully understand about how exact mechanism through which IVIG helps in treating the PANDAS. But according to National Institute of Mental Health study on IVIG showed a 60% mean reduction in symptoms of PANDAS patient. In plasmapheresis, uh, or a plasma exchange is a process during which autoimmune antibodies, aka autoantibodies, are removed from the blood, which is it is different from the IVIG in that it removes the autoantibodies that many such as things play a role in the development of PANDAS. In the American Society of Apheresis list plasma exchange as an accepted first-line therapy in the PANDAS. After a series of plasma exchanges, patients improved by 65% on average, and children experienced near complete symptom remission. Coming on to the summary and conclusion, the hypothesized association with the pandas and JBHS is controversial, as we have seen the controversies. And the children who present with the abrupt onset of OCD tic disorder should be evaluated for the group A beta hemolytic streptococcal infection. Children with abrupt onset of OCD slash tic disorder and the evidence of GBHS infection should be treated with anti-streptococcal therapy, which we have seen, along with the standard neuropsychiatric treatment for OCD slash tic disorder. Immune modulating therapy are not a cure, but helps in bringing up to 60 to 65% relief in the symptoms. These are my references. Thank you.